We are really fortunate to have Dr. Dan Frayne, president of the Mountain Area Health Education Center and co-chair of the clinical working group of the National Preconception Health and Healthcare Committee, with us today. As a reminder, the goal of our Preconception CoIIN project is to develop, implement, and disseminate a woman-centered, clinician-engaged, community-involved approach to the Well Woman Visit to improve the preconception health status of women of reproductive age, particularly low-income women and women of color. And we are thrilled to have Dr. Frayne joining us today to talk about prediabetes and the reproductive age woman. Turning it over to you, Dr. Frayne.
Thank you, Catherine, and thank you all for being here and inviting me. So I am a practicing family physician and have been really working hard to improve the health of women, both before pregnancy, during pregnancy, and after pregnancy, in their comprehensive health care for the last 20 years. So a couple of caveats about this presentation and disclaimers is that this is not intended to be a comprehensive nor detailed presentation. My goal is to present very simple and practical advice based on my experience as a clinician, my experience as a resident educator, and in seeing how we need to do systematic change in the routine care that we provide women. There's a lot of opportunities on doing this differently, and my hope is that by presenting some very simple, practical issues that happen every day, and by focusing on ways to address them, that we will get different results. And the results we want is a healthier woman, healthier pregnancies, and healthier families. So this topic is going to be about prediabetes. So the goals are going to be to talk about the screening recommendations and understanding who should be screened for sugar issues, the diagnostic criteria that are in place, what are our treatment options for prediabetes. And again, I'm not talking about diabetes. I'm going to be focusing on prediabetes. Diabetes would have an entire other talk on its own. I'm going to hammer home the importance of context of the reproductive goals and its impact on our decision making. Review the preconception care considerations, and then really kind of talking about, all right, what happens when pregnancy occurs. All right, so we're going to start off with screening, and this is screening for women who have no symptoms, right? So if someone comes in with symptoms that suggest they might have diabetes, that's not what I'm talking about. This is routine, saying everybody should get screened, and this is who should be screened. So the key thing to recognize is that prediabetes is really common. About 86 million people in the United States. Remember, we are a country of what, 330 million or so? So that's a lot of people with prediabetes. About 20 million, in addition, actually have the diagnosis of diabetes. So 6.8% of all pregnancies are complicated by pregestational diabetes, not prediabetes, diabetes. So again, this is a really common chronic condition with lots of implications for the health of women and pregnancy outcomes. The screening recommendations for screening for diabetes, again, just to clarify, we're not screening for prediabetes, we're screening for diabetes, and then based on those results, they can fall into a category of prediabetes. The recommendations are based on age and risks, and not every group has the same recommendation, so it can be a little confusing. I will say that as of this year, the United States Preventative Services Task Force has adjusted their recommendation for screening for diabetes to include a wider age group. So they have made it now start at age 35 to 70. This is not for everyone. These are screening for people with risk, and the risk that the USPSTF identifies is around weight. So anybody who is overweight or obese should be screened starting at the age of 35. That's according to the USPSTF. And by overweight, I mean a BMI of 25 or greater. And you can imagine that this is a very large segment of our population. The American Diabetes Association is a little bit more universal in their recommendations. So they believe that everyone should start screening for diabetes at the age of 45 and sooner if any risks. And there are a lot of risks for developing diabetes. And these include weight, hypertension or high blood pressure, family history of diabetes, a history of gestational diabetes, polycystic ovarian syndrome or metabolic syndrome with low HDL and high triglycerides, cardiovascular disease of any type. The race and ethnicity groups are pretty much anybody who isn't white, which raises an eyebrow to me as we start to understand the whys behind that. It's not necessarily about genetics. There's probably other factors going on with the risk of chronic conditions with those groups. And what I mean by that is African American, Latinx, Native American, Asian, all of those groups have increased risk for diabetes. And those are also all groups that suffer the effects of systemic racism. So the last risk that is on the list is physical inactivity. So again, when I look at this risk, I'm like, who in our general population doesn't have one of these? And so it kind of really does broaden out the group of people who should be screened. If someone is screened and their screen is normal, we should probably rescreen about every 3 years, but it's not clear in the data of how often and to screen. So this is kind of a general best practice guideline, but not a hard and fast evidence-based rule. So what is the diagnosis of prediabetes? There's 3 ways to test, and these are the ranges of those tests that would give the diagnosis. So for an A1C, it's in between 5.7 and 6.4. So a diabetes diagnosis begins at 6.5. For a fasting glucose, it's between 100 and 125. A diabetes diagnosis begins at 126. For a 2-hour glucose tolerance test, it's between 140 to 199. Again, a diabetes diagnosis begins at 200. So one of the key pitfalls that is often missed and misunderstood is these values can vary, and they're not perfect tests. You know, labs are not perfect, and you could repeat the same lab twice in a row at the same time and get slightly different results. And so it is important that we recognize that and get 2 different measurements at different times of the same test before we officially give that diagnosis. And I have to tell you that very few people in practice are doing this consistently. But I think it's important because once we categorize something, it should be meaningful. And we never want to label an issue that may or may not exist. The other thing to recognize is that anemia, so a low hemoglobin, can affect the A1C. The A1C is the simplest measurement to get because it doesn't require you to fast or do a 2-hour testing scheme. So it's often our go-to, an easy one. And in the moment, let's just screen you for diabetes. Let's get an A1C. But if you're anemic, it can actually give you a falsely high number. And so we need to recognize that. I also see in practice is that we are screening and we're getting these glucoses and these A1Cs, and it's falling in the prediabetes range, and there is no documentation of any discussion or any acknowledgement that value was abnormal. And one of the reasons is that most labs actually don't flag it as abnormal. They're only looking for diabetes levels to be abnormal. And the prediabetes range is not considered abnormal. Providers are also sometimes distracted by other reasons, and it's like, okay, well, it's not diabetes, so I'll address it next year, or it's not that big of a deal. It's not diabetes. And so I'm hoping that with this discussion, we can all agree that it's important to actually acknowledge it, repeat it, and then discuss about management and risk reduction. And one of the most important things to recognize is that prediabetes actually may be diabetes. And so it is not just a simple thing to brush off. The reason for that is that diabetes is actually a very long process in coming. I mean, in some cases, we're looking at 20 years in the making. The body is incredibly good at maintaining sugar control. We have so many mechanisms in our physiology. It's really a thing to marvel at, the amount of processes that the body has in place to maintain a normal sugar level. And therefore, once the body no longer has control of that sugar level, so many things have gone wrong for so long. And so I think that is so critical for us to pause on and recognize, because the treatment strategies and the recognition of how to improve and reduce risks also is not a quick fix. It's a long, big process. It doesn't come overnight, and it doesn't get fixed overnight. And so having good, clear discussions and education with our patients is critical. It is well recognized that diabetes complications that we think of as long-standing, uncontrolled diabetes complications of neuropathy, retinopathy in your eyes, and nephropathy with your kidneys, sometimes those are already present before diabetes is ever diagnosed. So that pre-diabetes number, people may already have symptoms. And it's because this has been going on for a long time, and it has to do with complex feedback loops with many organ systems, inflammation cascades that actually cause the nerve damage or the eye damage or the kidney damage. And so that inflammation is happening even when the sugar is still normal. And that's why we see this. So thinking about the diagnosis of prediabetes, it is really important for us to make it, because it's already late in the process. Damage is already happening. So the other side of it, though, is that not everybody with prediabetes is going to go on to diabetes. So it's not like that we should change our approach to the diagnosis of diabetes. Why don't we just make it earlier? Because it's not exactly true, and we still don't know exactly what are the markers and what are the factors that go into it. But there's more and more information as we focus on prediabetes that will help us with this. The importance of making life changes with the diagnosis of prediabetes cannot be overemphasized. And it's going to be the same life changes that we would want for anybody. It's the same things that we're talking about. It's diet and exercise and reduced stress and healthy behaviors. So these are the things that we're talking about even without the diagnosis of diabetes or prediabetes. But once we have the diagnosis, it gives us that urgency of saying, okay, we've already had damage. We have to make some changes for the long term. So it often is talked about. I'll say, okay, so prediabetes versus insulin resistance, and they're kind of the same thing. And people refer to this idea of the metabolic syndrome. And I have to say, in practice, it's often hard to get this as part of our standard approach. Metabolic syndrome is often not diagnosed, not thought about, because we're dealing with all of the components of it without just putting it together. It's really a constellation of data points pointing toward future risk. Although we often don't diagnose it, the information is usually all there. And one of the hard parts as a clinician is that the criteria is confusing. It's hard to kind of keep in our heads, and the guidelines vary. So it's a little bit of a challenge as a clinician to keep it straight. These are the 5 things that make up metabolic syndrome, and you only need 2 or 3 of them to get the qualification. So we're talking about elevated blood pressure, and it doesn't have to be hypertension zone. So a blood pressure of 135/85 is in this category. A low HDL or high triglycerides. The waistline measurement, which is one of the missing categories, is that we do not routinely measure people's waistlines as a measurement. And so whenever we're looking at data, do they have metabolic syndrome? It's hard to, that's the one data point that we have to actually intentionally try to get. But some of the guidelines include BMI, but not all. And then finally, glucose intolerance. And really that is synonymous with prediabetes. So it's really just a collection of risks that probably all are being addressed individually. And so the value of metabolic syndrome practically may or may not be there, other than focusing our attention that whatever is going on in the body is having an effect in multiple organ systems, and we need to make changes in order to improve risk. So what are these initial treatment interventions? So you make the diagnosis, the appropriate diagnosis of prediabetes, and you start to have a conversation with your patient. It's no surprise. It's fairly straightforward. It's about diet, it's about weight loss, and it's about exercise. That's what it's about. So the good news is that we are also getting more information about whether or not we can reverse disease. It's been an old adage in medicine that once you have diabetes, you always have diabetes. And the reasons for that are practical, is that diabetes probably took 20 years to get, and the damage is done. And so even if you get sugar control, there's still a problem in the system that can't be fixed. What we're learning is that that's just not exactly true, is that we can fix some things in the system. We can reduce inflammation. We can reverse some of the damage done if we are aggressive. And that's where these ideas of lifestyle medicine, which now actually has its own board certification for lifestyle medicine. And it's really just about having really good expertise about patient-centered coaching on diet, exercise, stress relief, healthy living, things like that, that can reverse disease. A big part of this is the information around plant-based diets. Plant-based diets are hard to comply with. It's a major culture change, but the evidence is there, is that they can reverse and improve outcomes and disease processes, particularly around sugar control. Many of you may have heard about this idea whether or not we should give medication for pre-diabetes. Metformin is our go-to medicine that pretty much everybody with diabetes should be on. It's the only one in its class, pretty much, that has long history and evidence for improving outcomes. So the question was asked, well, if you have pre-diabetes, would metformin help? Would it reduce the chance of progressing on to diabetes? Would it improve outcomes? There was a landmark study that showed yes. But it also, that same study that showed that metformin can delay the onset of diabetes, also showed that vigorous diet and exercise with a coach and at a gym did the same, if not better, than metformin did. So that just kind of drives home is that it's the lifestyle changes that we should be really focused on. There was a lot of chatter in the medical literature about the implications of starting a medication like metformin that has cost, that has side effects, that in a pre-diabetes scenario, and whether that should be the routine guideline. Remember, we have 86 million people with pre-diabetes in the United States. And so Do we want 86 million people on a medicine? And that's a challenging question. Only if it really, really helps. But if we know that diet and exercise helps, then maybe we should focus there. Also recognizing that not all diabetes, not all pre-diabetes progress to diabetes. And the flip side is that some with pre-diabetes already have diabetes. So definitely those should be on metformin. And so it becomes a little bit of a decision-making that should be patient-centered again, discussing the pros and cons of a medication, the interest and willingness of the patient to be able to participate in diet and exercise programs, and whether or not there is other factors in risk that would push you to say, oh yeah, we definitely should be on a medicine for you individually. All right, so context matters. So the idea of understanding prediabetes in relation to an individual's reproductive goals cannot be overemphasized. We do not do this well. We need to routinely ask the question, and what that question is not clear. What we do know is that there are very positive ways of asking questions about reproductive goals, and there's probably some ways that we shouldn't be doing it. The goal is, and the key is to have the conversation, and it is a conversation, and we need to have it frequently because it changes. So most of you have heard about the one key question, and that is, would you like to become pregnant in the next year? And there are 4 standardized responses to that, and that is yes, no, unsure, or maybe, and then I'm okay either way. And so it's the answer to that question that then leads to a conversation about the impact or around decision making, both for their reproductive well-being as well as to the effect of that with their chronic conditions. The PATH framework has gained a lot of momentum, and it's really about framing the conversation in a patient-centered way. PATH stands for the Parenthood or Pregnancy Attitudes. So is pregnancy desired? Is parenthood desired? How many children? What are your values around pregnancy? And then what is the timing of that? And then very importantly, how important is prevention of pregnancy to you? So that it really provides the framework of understanding where the patient's at, so that you as a provider can have that discussion that is centered around what the patient's attitudes and desires and goals are. Knowing the context of reproductive goals informs the discussion on treatment goals and choices for management. So we can't understand how best to counsel around prediabetes and its effects on future pregnancies or the risks if we don't know what those goals are. And so we need to talk about what the urgency of getting getting glucose under control, what the risks might be, what our medication choices may or may not be based on the timing of that decision. And then, of course, the need for further evaluations, really assessing further risk of the consequences of glucose intolerance. The other interesting thing about sugar, so prediabetes or diabetes when it comes to reproductive goals, is that many people with glucose intolerance have an effect on their menstrual cycle. So when glucose is out of control, it affects estrogen, and it can make folks anovulatory, and therefore they have irregular periods. What happens is once you start working on that and you get glucose under control, periods become regular, ovulation happens. And if you're not centering the conversation with both of these factors in mind, by getting the diabetes under control, you actually increase the risk for an unintended pregnancy. And so it is really critical to understand this in the context of sugar management. So in women who are not wanting pregnancy in the near future, the contraception discussion is important and critical. And there really isn't any contraindications for any method related to sugar. The contraindications and issues come up with any complications of other complications that would come along with diabetes, such as cardiovascular or hypertension or kidney issues or eye issues. So these would affect your decision making around that. The sugar itself is not a contraindication to anything. So I would like to just point out really helpful resources that are available that are designed to be point of care. The CDC medical eligibility criteria app is comprehensive and talks about any chronic condition and the evidence for or against certain contraceptive choices. The Bedsider website and resource is incredibly valuable in patient-centered discussions and decision-making around contraception. And then the Reproductive Health Access Project has lots of resources and handouts and is designed really well. So these are the three that I think any provider should be aware of and utilize regularly in having these conversations with their patients. So moving on the other side of preconception care, the most important aspect of management is around considering the risks and whether or not further evaluation to determine whether end organ damage exists. That's the most important aspect of preconception care when it comes to prediabetes or diabetes. The organs that are affected are the eyes, the kidneys, and the heart. And the reason why that's really important is creating awareness and strategies that pregnancy can make these conditions worse. So retinopathy can get worse during pregnancy. Kidney failure can get worse during pregnancy. Heart issues can get worse. And so knowing that they exist before provides the opportunity to prepare and optimize health and also make decisions that the patient can go into the decision-making process with all the information. So the goals will be to optimize glucose control, checking sugars regularly, and then this would be important to consult specialty care, maternal fetal medicine, if there's any concerns for overt diabetes or vascular disease. I do feel strongly that people with pregestational diabetes should have a maternal fetal medicine consult to provide the highest quality of care and evaluation and discussions prior to becoming pregnant. Prediabetes, only if there's evidence of diabetes or end organ damage. So what is that preconception care kind of standard review? It's not just about the one issue. It's really a comprehensive discussion and review of all the risk factors and things that might play that could be optimized. I often get frustration or lack of awareness or education around what does preconception care actually look like. And so this is kind of my list. I use it as a dot phrase to remind me and then document kind of a standardized approach and discussion around the different themes that need to be reviewed and discussed. So I actually think it's fairly straightforward to do it this way. I can actually do this even in the moment and do it fairly quickly with my patient, even if the visit wasn't designed for that. So we're talking about the family planning and pregnancy timing, which we've already started to discuss. We're looking at nutritional status and emphasizing the importance of multivitamins with folic acid and talking about BMI, which again, we're usually already discussing. Reviewing the infectious disease risk and immunization opportunities. So now we have to add COVID-19 to that vaccine list, flu vaccines in season, chickenpox and rubella vaccination if they're not immune, and then making sure that we have the opportunity to treat sexually transmitted infections before pregnancy is ideal. And let's not forget about the Zika. It still exists out there. So then reviewing other chronic illnesses that may affect. So prediabetes often does not come alone. There's often many other things going on. And so putting it all into context for the whole person, reviewing those medications, which there's often medications that would need to be reviewed and addressed. Screening for substance use, tobacco, alcohol, or drug use, discussing previous pregnancy outcomes and what that might mean for a future pregnancy, and making sure that we're all clear about risks. And then the genetic risks, such as age, race and ethnicity, family history, and any male factors that would go into decision making. Screening for mental health, and understanding the impacts of pregnancy and other stressors that sometimes can get worse as pregnancy develops. And then intimate partner violence, and having a standardized screening approach to partner with patients so that they have a safe and stable relationship. All right, so finally, what do we do once we're pregnant? So there's a new term. We've been using the term pregestational diabetes for a long time, meaning diabetes that exists before pregnancy. And now that we're diagnosing a lot of prediabetes, you know, it's like, so what do we call that? And what does it mean? So I think it's appropriate to use the term pregestational prediabetes. So they had prediabetes before they got pregnant. And so then what does that mean? So far, what we know is that it does increase the risk for hypertensive disorders of pregnancy, so preeclampsia and whatnot. It is different than gestational diabetes, but it's probably all on a common spectrum. So sugar issues in pregnancy all affect both mom and fetal growth. So we need to handle them and approach them in similar ways. We just don't have enough data yet to say, should we treat prediabetes like gestational diabetes? The answer is probably no, but we're going to be working on sugar and checking on other factors as they develop. And around serial fetal growth monitoring is probably appropriate. So in conclusion, the key pearls to take away from this is that first, screen appropriately, make sure that we actually get 2 tests for confirmation, and avoid any of these confounding variables such as anemia or illness or stress or other reasons that would have affected that initial measurement. And then even, or just as importantly, when we find it, diagnose it and discuss it. It matters. So we don't want to forget about the effect of improved glucose control on ovulation. That is often not thought about before until it's too late. We want to focus on the whole person care, that recognize that prediabetes and diabetes is often not alone, that weight issues and risky behaviors such as alcohol and smoking, hypertension, cholesterol, thyroid issues, mental health, all of these things are often coming at the same time. That the understanding the reproductive goals and context are crucial to patient-informed decision-making, as well as clinician-informed decision-making. And then hammering home, both on the clinical side and on our patient population side, that preparing for pregnancy is valuable and important. Proper evaluations, understanding and mitigating risks will improve outcomes. And not forgetting that a daily multivitamin with folic acid more than 3 months before prior to conception is the recommendation, and should be encouraged for everyone. So that's what I have. Thank you very much for your time and attention, and I look forward to any questions or discussions that develop.
Thank you so much, Dr. Frayne, for a wonderful presentation. Really appreciate that. Just want to highlight a few resources that are available for folks. We have our showyourlovetoday.com website, which is directed towards consumers and people of reproductive age, and that information is available in English and in Spanish. We also have for providers, beforeandbeyond.org, and that includes resources such as online training modules and our Women's Health Practice Bulletin. And then also, if you haven't already, please do sign up for our newsletters. You can use this QR code or go to that website link. And there's also a biweekly research listserv from the CDC if that is of interest to you. And of course, everything is most up to date on our social media properties. So please do visit those whenever you have anything that you're looking for. So thank you again, Dr. Frayne, for a wonderful presentation. We really appreciate it and hope that you have a wonderful day, everyone. If you do have any questions, do feel free to email me, Catherine_Bryant@med.unc.edu. And again, thank you so much, everyone. Have a wonderful day.